training at the John A. Burns School of Medicine and finished his internship at the University of Hawaii Transitional Residency Program. He then moved to Buffalo, New York, where he completed his dermatology training at the SUNY Buffalo Dermatology Residency Program. For the past 8 years, Dr. Kitagawa has worked as a private practice dermatologist in the Kuakini Medical Plaza, performing both medical and cosmetic services, and he also participates with inpatient consults at Kuakini Medical Center. Please help me welcome Dr. Kitagawa.
Thank you all for having me here today. I'm honored to do this, and thank you, Lauren, especially. So my lecture today is common skin conditions in the elderly, and some of them may not be that common, but things that I would want you guys to at least be aware of when you see them. And by the way, feel free to stop me throughout the presentation if you have a question. I have no financial disclosures. So the learning objectives today, there are 4 that I created, and hopefully we can get through those today. This is the main one, is formulating a good differential diagnosis. And basically I'm going to do this through pictures, so there's going to be a whole lot of pictures in this presentation. Identify emergencies that require hospitalization. Luckily there aren't too many of them. Identify what should be referred to a dermatologist and what should be treated on your own. And then formulate an appropriate treatment regimen for the most common skin diseases that you guys will see. And just a quick show of hands, how many of you guys are geriatrics and how many of you are more, like how many are geriatrics? And then there's fellows as well. And then how many of you are just internal medicine or family practice? That's okay. And then any other specialties or anything else? What is nursing? Okay, got it. So skin diseases in the elderly, it makes up a big chunk of problems that elderly patients have, and directly evidenced by whenever I go to a birthday party or anything. And you get asked millions of questions all the time. What is this? What is this? What is this? So we all know that skin, everybody has something on their skin that they don't like. And even if it's not medically significant, it still bothers them. You have a sunspot on the face, you have a bump on your arm. There's a lot of changes that occur in the aging skin, and most of them are directly related to chronic sun exposure. They actually do say that under the age of 18 is when you accumulate most of your sun damage. So, I mean, it's not like you're out of luck if you start putting on sunscreen later, but you know, for kids and grandkids, start getting them early with the sunscreen and protective clothing. So what functions change? So there's an increased susceptibility to UV radiation, and that's thought to be because of the decreased density in melanocytes in the skin. You have an increased risk of skin infections, thought to be the decreased number of Langerhans cells. Slower wound healing, so they do say that keratinocytes move slower, they're more sluggish appearing, and there's also altered fat metabolism. And then collagen degradation and loss of elastic tissues lead to the wrinkles and the fine lines, and decrease in subcutaneous fat makes people more prone to injuries given that they have less padding. So let's get started. The way that I'm going to do this, so when I was in residency, there's about 6 to 8 of us, and we would sit around a table after our clinic on Thursday afternoons or Thursday evenings, and there would be one attending, which we loved. Basically, he would show all these picture slides or Kodachomes, and he would go start off with the interns and say, put up a picture and say, what is this? And you give a differential, and you just keep saying, what is it? What else? What else? And you just keep on going until you run out of things to say. Then he would move on to the next one, and then he would move on until we exhausted all the residents. And then he would show another slide and do the same thing over and over again. And in the end, we always said syphilis. We always said sarcoid, because that can be anything on the skin, but I don't want to hear that from you guys. So no syphilis or sarcoid we're going to have as differentials. And if you want to pipe up, you can. If you want to just formulate it in your head, I'm okay with that as well. But feel free to talk. But here's the first one. Anybody want to just shout out some things that are thinking off the top of their head real fast for this one? Simple things like eczema, dermatitis, allergic reaction, those are all definite possibilities. We start to go to this now, so you do have some bulla and vesicles on the lower legs. So this does have a much more broader differential diagnosis in the elderly population. So maybe I'll just list them for you guys. So, some things you want to think of. Absolutely, stasis bulla, stasis dermatitis. Thank you, Kory. It's a good one. The stasis bulla, of course, will be in the background of significant swelling and stasis, but that can look just like this. and it often will have, actually all bullets can often have that yellow it's that yellow straw-colored fluid that comes out, and that's normal for stasis bulla. Absolutely, bullous pemphigoid is another great thought, tense bulla. There's also bullous arthropod. So people who have, I believe it's CML, one of the leukemias, they have a much higher chance of getting vigorous bug bites that turn into blisters often. Diabetic bulla, so if they're really poorly controlled diabetes, you can get these on the lower legs. Less common things, like porphyria, you would normally know that earlier in life most of the time. And EBA, you guys have heard of epidermolysis bullosa acquisita, so that can be more strictly in the elderly population and can be associated with underlying malignancy. And then we start to go with this more, so tense bulla, erosions. And then this is my last picture of this one, so another tense bulla. So this is bullous pemphigoid. Oh, good job. So it's definitely a disease of the elderly population greater than 60 years of age. The incidence, the 6 to 13 new cases per million is probably underestimated. I think we definitely see more than that. I think it's just under-recognized. And men are definitely greater than women. So it's an autoimmune disease process. It's thought that your immune system attacks antigens that are in the basement membrane zone, and that causes the split in the skin and the blistering to occur. So the hemidesmosome, you don't need to put too much thought into this, but basically there's different layers in that basal layer of the skin that can be attacked, causing different bullous diseases that can occur. So the clinical features, and this is the part I think most people don't realize, is that early bullous pemphigoid can absolutely look like eczema or urticaria. I mean, it can look very non-specific. So I would tell you guys, if you have a rash that you're treating, and you're treating it for months and months and months, and it's just not getting any better, or it gets better, but it just keeps coming back really quickly, I mean, it's a really good thought to consider bullous pemphigoid in your differential diagnosis. Your typical bullous phase would be more tense blisters, symmetrical usually, and flexural aspects and on the trunk. And then oral cavity, definitely, about a quarter of these people will have oral lesions. If you remember from medical school, they always say, well, pemphigus is in the mouth, pemphigoid is not, but that's not really true all the time. And then drug-induced will normally be a younger age. You'll absolutely see that with diuretics most commonly is what we see. So I'll normally see like 50-year-olds who all of a sudden have bullous pemphigoid and they were started on medication. Diagnosis, that would be something you would normally refer because you do have to put it in a special medium, either Zeus media or Michelle's. So you would probably be referring this patient for the biopsy for dermatology. And then the prognosis, I know in a lot of the textbooks they say that most of it resolves over a period of 1 to 2 years. I gotta say that most of these relapse or recur. We treat them, even while you're treating them, they start to recur. After you finish treatment, about half of them recur. So I do think it really has a high recurrence rate. I think that mortality rate is inflated, but that probably also includes the medications we give to treat the problem. You know, some of them are pretty heavy-duty medications, so infection is the #1 cause of death in bullous pemphigoid patients. And then treatment. So this is the order that I normally would go in to try to treat these people. So if it's localized, there's studies showing that clobetasol has the same efficacy as prednisone for localized disease. So you don't need to jump to prednisone. Clobetasol is sufficient for localized disease. Topical calcineurin inhibitors are Protopic or Elidel. Good luck with Medicare trying to get that covered all the time. Oral steroids are the mainstay for treatment. And then often I'll do the tetracycline class plus or minus nicotinamide. And normally I'll do about 500 to 2,000 milligrams per day of nicotinamide with minocycline or doxycycline. Then we start to get into the laundry list of other immunosuppressives. And I will say to the elderly, probably mycophenolate would be my next best choice because I do think it's the least devastating for elderly patients. I'm not really destroying their liver or anything like that. But then I'll go to methotrexate or azathioprine next. And rituximab actually has really, really, really good evidence of sometimes curing the disease. It's just, again, good luck with Medicare covering that. Rituximab actually just got FDA approved for pemphigus. So sometimes you can finagle the words and say pemphigoid, pemphigus is pretty close, yeah? All right, any questions about bullous pemphigoid before I move on to the next one? Yes?
In the past, I've seen Dapsone used.
Mm-hmm. Yeah, so definitely, because bullous pemphigoid, if it has a stronger neutrophilic component to it on the biopsy, they do say that Dapsone can actually have a little better chance. And sometimes some of those were misdiagnosed as actually bullous lupus. So then dapsone actually works really good for bullous lupus. But you're right, I mean, definitely in the biopsy, if you see a lot of neutrophils, you can consider dapsone as a treatment option. Yeah. So the next picture, let's hear some other voices here. I'm working a lot on this side of the room here. Let's hear some from that back corner over there. Anybody want to think of stuff that this could be? And there's no wrong answer, quite honestly. Silence is deafening. Yeah, scabies is a great choice. Along with scabies also goes kind of the psychogenic or neuropathic pruritus or itch, which you guys probably see quite a bit. This picture is important, and I put this one up because there is that sparing of that mid-back. Yeah, so a lot of times if you have a dermatitis or you have a rash that they're allergic to a medication or something they're putting on, there's no reason why the middle of the back should be spared, right? So this is more a pure itch that they're scratching and they can't reach the middle of their back. These are pictures of finger web spaces, toenail spaces, and lovely genitals over there. So this does have another differential diagnosis, especially in the elderly. You should at least think about nutritional deficiencies when you have acro or growing crease involvement. It does look different than this, I will say, but I mean, you can at least put that in the back of your mind that nutritional deficiency is a thought. There's one other thing you could add. You could add tinea for this as well. Yeah. And then I think we're getting a little more specific now at this point. The only thing I would add for the left picture would be dyshydrotic eczema, so a type of eczema, but on the right over here you can see that I'm basically showing you a burrow. So, scabies, we all love scabies. So scabies is everywhere. I mean, the very first patient I saw when I came back from residency was not someone who was in a long-term nursing home facility. It was a random person who was working at, I think, Subway or something, a 20-something-year-old boy. So, don't only pigeonhole to people who are in nursing homes. And I love this prevalence rate, 4 to 100%. It means nothing. Definitely transmitted directly by close contact, either sexual or personal. And then crusted scabies, we've all heard about that, right? That's when you have the crust all over the body and you can scrape anywhere and get a scabies mite off of that person. So scabies in general is caused by the Sarcoptes scabiei, the human variant. People ask me often, what about dogs? So dogs have mange, which is a scabies variant. It can bite people, so you can still have bites from the mange, but it's not going to live off of humans, yeah? So it'll be temporary. They live completely within the epidermis, and females can lay a whole lot of eggs. I mean, 3 eggs a day, I mean, you're just multiplying that, and it should be making you itchy right about now. Most people have about only 10 to 15 mites. So don't get the impression that everything you see on the body is a scabies mite. It is absolutely not. It's your allergic reaction to the feces or the scibula, the eggs or the mite. It's not scabies everywhere. Yeah. Now in Norwegian scabies, you can have hundreds. I mean, you can definitely have tons of mites. They only live a certain amount of days off of the human host, so that's a good thing. You're not going to really have it in your environment for long periods of time once they leave. And it can take a while after they get exposed to someone else to develop the infection, but if they get reinfested, like any infection for the most part, you can get a quicker response. Scabies carriers are people you can actually find scabies mites on them when they're not itchy at all, and those can be like close contacts or whatnot, so it is good to treat close contacts. And people ask, what is considered a close contact? So there's no great definition for that, but I mean, using more common sense. I mean, family members who prolong contact with them. I mean, if you have a nursing aide or nurse or respiratory therapist or someone who is with the patient more, you probably should. I would say that if it's just someone doing rounds, probably not. But if it's someone who's taking direct patient care with them all the time, I would treat myself. Classically, the itch is worse at night and with hot showers, and basically you can have a non-specific excoriation all over the place. The burrows are most commonly found in finger web spaces, belt line, armpits, genitals, feet. Those are the areas I look for to scrape. And then this is a picture of a burrow when we look at it under our dermatoscope, which is our magnifying glass. You can kind of see, You can kind of see there's that, on the right-hand picture, there's that little trail going down, and the triangle where the arrow is pointing, that's actually the scabies mite. And you can see the triangle on that one too, that the arrow is pointing to. Those black dots are probably the feces of the scabies. Picture of a scabies mite, and you can see the eggs on the top over there. This is more classically what I would see with the KOH. That's what it looks like when we do the scraping. The scraping for this, so it does not need to be done with mineral oil. I mean, that's the classic board question, how would you scrape it? You can do it with regular KOH. I mean, unless you want a live one, you can do it with something else, but we don't really want them alive. So KOH is perfectly fine. And then, yeah, anybody getting itchy? So treatment of scabies, you should treat the infected people with one treatment and then 1 week later because of their life cycle. Close contacts, I sometimes just treat them once if they're asymptomatic. I don't necessarily always treat the close contacts twice. And then my instructions, I do recommend washing everything in hot water. If they can dry it on a clothesline outside, that's better. If not, you can put it in a bag for 10 days or do it with high heat. And we mentioned about treating close contacts. The last thing, the post-scabitic pruritus is extremely common. So patients, you have to educate them when you're treating them that you will still be itchy probably for a month. Because they are. I mean, you're killing the mites in the body, you still have the allergic reaction. So normally we'll treat that for symptomatic relief with antihistamines or topical steroids. But they almost always will be itchy after the treatment for at least about a month after. So I like permethrin cream as my first line. There is a lot of resistance to it, but I still think it works for most people. Lindane, I've never actually used that. Protamidin, I used that in residency and it never worked, so I wouldn't waste your time with that. Sulfur ointment, the board question for that is normally if it's a pregnant lady, it's considered more safe because I believe it's a category B in pregnancy. But you can still use permethrin, so I don't see why not. And then ivermectin we do for resistant cases if it keeps recurring. And then any questions about scabies? Yes? Yes.
Once or twice?
So if you guys do an exam on the roommate and there's absolutely nothing on the roommate and they're completely asymptomatic, I think you're justified in treating them once if you want to. I mean, you're never going to go wrong treating them twice if you're really worried about it because it's not going to harm them at all. But I would probably have just treated them once in that case if they're asymptomatic.
Do you have to do them on isolation for 6 months after the treatment is completed?
Good question, because I actually had one with, I think one of, I don't remember which one, that patient, that family was totally not following instructions, but, so for that one over there, that's when they treated every single day, was it, for like, oh yeah, every single day for like a month, they were putting permethrin on that, a mean rash after that. That was impressive. So, what was the question again? Oh, isolation, yeah. So the isolation, so technically, the mites are all killed after that second treatment. So technically, you really don't have to go under isolation after that first week, but you gotta realize that there is a lot of resistance to it, you know, to permethrin, and some people do take another treatment down the road. The right answer would be, though, that technically after a week, they shouldn't have to be on isolation. They're still gonna be itchy, though, so it's gonna make you guys nervous to take them off of isolation. But, I mean, that would be the correct answer. They should all be killed after that second treatment. Yeah. Or at least in a single room, you know, not with, I'm assuming that's what isolation means, right? You're not putting them like in a plastic wrapped room. No, not really. Okay. Any other questions about scabies? Yeah. So in the elderly population, I use it less likely because of the risk of side effects and polypharmacy. There was a case we had in residency where someone had liver failure from it, but they don't really know if it was from the medication or not. And the other thing was at a certain point in time, it was really, really hard to get ivermectin. So I don't know about anymore if it's easier to get it, but we actually couldn't get it at any pharmacies or anything. So kind of like doxycycline, where for some reason things just go out of supply for a little while, but they come back. But I would normally go with permethrin because there's no toxicity with it, or minimal. So it's going to be a similar case. Yeah, so there should be some similar things going on through your mind with this one. Absolutely, that's a great thought, folliculitis. And expanding on that, different types of folliculitis then. So you could have your run-of-the-mill bacterial folliculitis, which is your common one. You could also have pityrosporum folliculitis, which is more intense itch, all of a sudden breakout all over the place, more trunk normally, and just a lot of pustules all over the place. And that's in people who are either immunocompromised or everyday people in a hot, humid environment. So people who have been doing hot yoga or sweating a lot, absolutely can just break out of nowhere. And that's something where, unfortunately, if you give them antibiotics, you will make it worse. A pityrosporum folliculitis, yeah. There's a couple of things we can think of for this picture. I hear a murmur over there. I think I heard someone say possibly psoriasis. Eczema is definitely another thought as well, yeah. I wouldn't say fungal on this one, doesn't look fungal at all to me. So I would say psoriasis or eczema are good thoughts. And then the favorite picture again, I just copied the same one from the last one. So again, we're knowing that this is not more of an eczema problem then, because it shouldn't spare the mid-back, right? So that throws eczema out of my differential diagnosis. So this is just your typical itchy person who keeps scratching at themselves for no reason at all, which is probably like 75% of your patients, right? I mean, they just itch and they itch and they itch. So there is an algorithm you should be thinking in your mind on what things you should be ruling out, because you don't want to miss anything important. So number one, I mean, bullous pemphigoid, they might just start off with an urticarial phase, and they might just be itchy at the beginning and it might be transient. Scabies, definitely. Dry skin, we love to put moisturizer on everybody. It doesn't cure most people, but it helps with some, so moisturize the elderly, their skin does get dried out. Dermatitis repetiformis, I wouldn't worry about that, because it's extremely rare, it's a unicorn, you're not gonna see that or see or whatever you call it. Medications, definitely a high risk for itching. And I can't even really tell you which ones are going to be more likely, because all of them can cause itch. I will say, like in photosensitive areas, we do think more about like diuretics, so like hydrochlorothiazide, furosemide, even simvastatin can definitely cause hypersensitivity in the exposed areas. ACE inhibitors, ARBs, those can all cause photodistributed itching. But I mean, in general, any new medication that was started within the past couple months is a possible candidate for that. And then I always ask about renal status, hepatic status, and if there's any poorly controlled diabetes, thyroid function, and all of that kind of stuff going on. If all of those are negative, then you kind of start to fall into the, you don't want to say they're crazy, but in the psychogenic category where they're just scratching and scratching. Actually, that brings up dementia. So definitely dementia people can itch more than people who don't have dementia. And then I do order an SPEP every once in a great blue moon. Because definitely multiple myeloma can once in a while masquerade as just itch and no other symptoms at all. So moisturizing, topical steroids, topical calcineurin inhibitors, again, are treatments of choice. Doxepin cream is a topical antihistamine. You could just do over-the-counter Benadryl cream if you wanted to. Sometimes we'll do anesthetics that are topical, and menthol, camphor, and capsaicin are all to try to ease the itching. Have any of you ever used capsaicin before? Not really? Yeah, it's a chili peppers, and basically it burns the heck out of the skin, but it makes you not itchy anymore. So they used to use it a lot for shingles, puerpetic neuralgia, and it's really sore, but it takes the other problems away. Systemic treatment. So oftentimes if we fail the topicals, we'll talk about systemic treatments with the patients, and I often will do the non-drowsy antihistamines first, like levocetirizine, cetirizine, Allegra, Claritin, those type. They often don't work. I mean, they're really not that good for itch. And I'll even dose it twice a day if we need to, so I'll do the 24-hour dosing twice a day. Then we'll try to go to the low-dose sedating ones, and if they can tolerate it, I'll push the dose. Doxepin, I normally reserve that for like the 60, maybe 70 the oldest, but I normally wouldn't do that for the elderly. Gabapentin, so we've been using that quite a bit for the past couple of years now, and that actually does have some decent results. Takes a while to work, but it actually can work pretty good in some people who just itch. Mirtazapine, if you have your older person who's not eating well either and they're itchy, why not? I mean, it might get them a little more weight on their bones, and they might also help to stop itching as well. It's probably just the antihistamine effect though that helps with the mirtazapine. Naltrexone, thalidomide and phototherapy are rarely used, but they are alternatives that I've at least tried once or twice, and they work okay. They're just not great. There are new medications that are coming out in the pipeline, and this was as of earlier this year, and they are NK1 antagonists, and they're supposed to be great medications for itch. I forgot if it's oral. I think it's oral. I don't think it was a cream. So I'm looking forward to that because that could possibly help out a lot. And any questions about just prurigo nodularis, which is the Picker's nodules, or lichen simplex, which is the rubbing and the scratching or anything like that? Next one. So again, eczema, I think right can fall under this category. This is also an ER favorite, where they'll start to call this bilateral lower extremity cellulitis and consult any number one of us. But they've gotten better though. So it used to be really bad before, but I think it's actually gotten better. I mean, it's difficult to get bilateral lower extremity cellulitis. I mean, you can, but I mean, that's not that common, yeah. So I heard someone murmuring it over there. It probably, you're on the right path, stasis, you know. So this shows you kind of that inverted champagne glass appearance. So this is acute lipodermatosclerosis associated with stasis changes. We start to get some stasis ulcers, yeah, and erosions. And then this was one of my patients. So the medial aspects of the lower legs are the most common area to get those stasis ulcers. One quick little fact about stasis ulcers and stasis dermatitis. Very sensitive to contact dermatitis on lower extremity rashes. So you can use like Neosporin, you can use lanolin containing products anywhere else in the body with no problem. But when you put it on these lower extremity rashes, the incidence, I think, of like 50% for Neosporin in some studies, where they can get what's called a contact dermatitis in the legs, and then an itch reaction all over the body, where they just start to get itchy all over the place. So no Neosporin on those lower extremities. I mean, Puricin is fine, Nitrosilbidine is fine for lower extremity ulcers if they're diabetic and you're worried about gram negatives, but I would almost never use Neosporin on someone who has that on the lower legs. And then lanolin containing products, so Aquaphor and Eucerin have lanolin in it, and that has a lower chance, but it still has a risk of that widespread rash. So definitely most common causes are caused by venous hypertension. Patients don't like when I say their valves are incompetent, but the valves don't work as well and they reflux the blood back down, venous blood supply back down. You also have to make sure they don't have liver, kidney, or cardiac functions, and that's when I give my nice little punt back to the primary care doctor to say, make sure they don't have that. The slowing of the blood in that area leads to distension of vessels and it leads to edema and chronic inflammation. Definitely worse at the end of the day. When they wake up in the morning, their legs are pretty good. As the day goes on, the swelling accumulates over time. You also want to make sure they don't sleep in a chair. Because if they're sleeping in a chair, they never have a chance for the fluid to come back. So, yeah. I already mentioned about acute lipodermatosclerosis. That is the classic bilateral lower extremity cellulitis. Red, firm areas in both lower legs. When it becomes more chronic, you guys have probably seen this, it's hard skin. And you know, it's like you push on it, it doesn't even have the edema anymore, it's just solid skin in the lower legs. And that's what you're trying to prevent, because that is the chronic changes. And then you can also get the venous ulcers, and I already mentioned that contact dermatitis with the secondary itch reaction. So treatment for stasis dermatitis, lifestyle changes, the usual salt restriction, leg elevation, definitely compression stockings. I normally tell my patients, put it by your bedside, and when you wake up in the morning, if you can, before you go shishi, put the stocking on first. Because as soon as you get out of bed, the swelling's gonna start. And then take it off normally when you shower at night, and then try to keep your legs elevated when you're watching TV or whatnot. They should be replaced normally about every 6 months. And there's of course different pressures. This is the one that I use the most, but it is a little tight on some people. Calf exercises, that stimulates the blood flow to come back. Surgery, vein stripping, I'm not a big fan of that. I think the endovascular laser ablation looks better now. And it has better success rate as far as I'm concerned, but they're both good treatments for the underlying cause. And then for the stasis, I use topical steroids, and we can use diuretics for the swelling.
What kind of focus do you use for steroids?
So topical steroids, I'll normally go with mid, so I'll normally do triamcinolone. And then if they don't respond, then I'll do a higher potency, but I'll normally start with triamcinolone. And I'll normally do the ointment rather than the cream, because again, that small risk of allergic reactions with that secondary itch reaction. I'll normally almost always do only ointments for the lower legs. It's messy, but it's a lot lower incidence of allergic reactions. So We talked about treatment. So I mean, workup, I mean, you can definitely order a Doppler ultrasound, to see if there is any venous insufficiency or varicose veins that could be treated. You definitely want to control infection. And like I mentioned, Silvadene is good for more either diabetics or people you think are gram-negative. And Mupirocin, it can cover a lot of different things. I do mechanical and chemical debris in my office. So chemical is Santo, and I think you guys use that on the floor. I see that in some of your guys' patients, yeah. The one note about Santo is really, if a wound is not getting any better significantly after about 3 months, Santo's probably not working. Yeah, I mean, it's not meant for chronic, like 1-year use. It's supposed to be an acute thing to get rid of the granulation tissue, and then you should not have to use it. It should be shrinking. One of the wound nurses told me, like almost in half, like every 6 weeks or so, the wound should be shrinking. Okay. Proper wound dressings are imperative, so if it's really oozing and leaking, I normally will use more like an alginate or something that can hold all the fluid. If it's something that's kind of more dry, you can do your usual, your tegaderms or your duoderms and those kind of things. And then chronic wounds are candidates for grafting. So we also do this in the office. I'll normally use things that contain, I won't use the name of the company, but they definitely contain matrix cells of the extracellular matrix that you can use to graft in those areas, and they help to speed the wound healing significantly, and they have to come in once a week to apply those grafts. And it's covered by most Medicare plans. You can also use growth factors or other things as well. Any other questions about stasis dermatitis or stasis ulcers? Okay. Yes?
For insurance coverage, if you're considering someone for a graft,
Mm-hmm.
about how long do you say that you have to feel or is there any care?
So 1 month. So really short time period. Yeah, so 1 month of treating it with, treating it, not just observing it, so actually treating it either with like Santo or debridement or antibiotics at the very least. But most insurance companies are 1 month. And then you do it, there is specific FDA indications for it. So stasis ulcers are covered under MOS, and I believe diabetic ulcers are covered. And most of them, Medicare is pretty easy with this, surprisingly. It's actually very easy to get covered. Yeah. The grafting process is a little pain, but it's not too bad.
Question. Do you want to comment on hyperbaric oxygen?
Absolutely. So hyperbaric oxygen is absolutely another great option. It's just, I suppose for some of the more sicker elderly, it would be a difficult option to try to get them down there. But if they're a very high functioning elderly person, hyperbaric oxygen is great. I actually did a rotation when I was in transitional residency over there, and they do a lot of good stuff. We use it for chronic wounds all the time. So yeah, great thought. I didn't even think about that one. That's a good one. Yeah. And of course, it's so convenient in Kwakini, right? And that's also normally covered by insurance very well as well. Yeah. So this one over here, for the interest of time, I'll move it along a little faster in the differential. So, things I would be thinking of: seborrheic dermatitis, psoriasis, less likely a contact dermatitis or something fungal. When you start to see that scaliness by the eyebrows on the picture on the left and around the nose, still psoriasis versus seborrheic dermatitis, but you're kind of leaning more towards seborrhea at this point. And then behind the ears is common, in the ears is common. So, seborrheic dermatitis. I threw this in here because I'm sure you guys see that in almost every patient. There's definitely infantile and adult forms. Adult forms definitely later in life, and definitely associated with humidity, stress, and I listed some other conditions that might be more specific. So immune suppressed and HIV, Parkinson's disease, depression. A lot of those things can be associated with worsening seborrhea, and I actually don't know the reason why. I tried looking it up and I couldn't find an answer why. I think the prevalence is way higher than 5% in Hawaii. I think probably 50% of people in Hawaii have seborrhea, some form of dandruff or something on the face or scalp. So they thought it was caused by malassezia, which is a yeast, and now they found out that that's very common on the skin in general. It's a normal flora. It is in higher numbers when people have active disease, but they think it might just be more reactive. In any case, they do know that there is active sebaceous glands that contribute to this problem for seborrhea. And that's why a lot of our initial treatments are often antifungals, right? So you can use ketoconazole shampoo, cream, cyclopirox shampoo. They all work okay. Distribution, we're all pretty familiar with it. One area that a lot of people miss is the mid-chest. That's an extremely common area for seborrhea as well. Dandruff is on the spectrum of seborrhea. It's just a very mild form. and I mentioned sun and heat. Those are the main ones. Treatment. So, does the topical antifungals work because this is a fungus? I mean, some people say, other people say, well, ketoconazole and cyclopirox have almost the same potency as over-the-counter hydrocortisone as far as steroid properties. So it may just be their anti-inflammatory effects rather than its actual antifungal effects. But it's a lot safer than using a steroid long term. So we'll often start off with that. I'll normally do ketoconazole shampoo or low-cost shampoo about 2 to 3 times a week, or Selsun Blue and Head and Shoulders a couple times a week. Then we start to throw in the topical steroids if it's not getting any better. And I normally hit it with stronger topical steroids. So I'll normally do fluocinolone solution or even clobetasol solution. And I'll do it for about a week, maybe 2 weeks. And then I'll give it a break after, 2 to 4 week break before you use it again. I like to cycle it. And then calcium iron inhibitors, unfortunately, they don't have a solution. So if it's in the hair, you're out of luck. But if it's on the face, I love Protopic or Elevate. I think it works really well. And it's safe. Okay. So you can kind of see some of those scaly keratotic papules on the forehead. Some thicker ones on the ear, and I don't know what part of the body that is on the right, but I don't know, could be a face or a hand. And then you see forearms like this in chronic sun damaged people as well. So differential diagnosis-wise, I mean, sure, I mean, you could think of on the lungs of dermatitis again, unlikely. You could think of gut-gate psoriasis or smaller types of psoriasis, but generally speaking, these are mostly going to be actinic keratoses. So very, very common, definitely in lighter skinned individuals with a lot of sun exposure and prior history of AKs. Elderly have more of these, and definitely immunosuppressed population. And then the bottom thing is interesting to note is that, so an individual lesion transforming into a squamous cell is less than 0.1% per year. But you gotta realize most people don't have one lesion. I mean, they normally have upwards of 10 to 20 lesions. So I mean, the cumulative risk factor, I think they said over 10 years for the person who has 7 or more AKs is like about a 10% chance of getting a squamous cell cancer. So it's out there, and you definitely want to treat them if they have a lot. You also have to weigh the risk of treating like a 95-year-old person who has like 4 or 5. I mean, I don't normally, I'll be honest, I normally leave those alone because they've lived a good life, and the chance of one of these turning into a squamous cell is so low in the first place, I at least give the family options of treating it or not. Definitely caused by UV radiation, and it's in a spectrum of all of these things that cause tumor suppressor 53 mutations. So actinic keratoses, squamous cell carcinoma in situ or Bowen's disease, and then squamous cell carcinoma are all along the spectrum of disease. So they're definitely only on sun-exposed areas for the most part. They're characterized, a term that a lot of dermatologists will use are gritty. I like keratotic better, so I call them keratotic erythematous papules. They do often have a burning or stinging feeling in a lot of people, and sometimes you can't even see them, so palpation is extremely important. If they say an area burns, then you can kind of feel that grittiness. The lower lip, sometimes people will say, oh, I just have dry skin, but it's only on my lower lip. There's only 2 things that I would think of on the lower lip if it's really scaly. There's a lip lickers dermatitis, if they keep licking their lower lip, or actinic cheilitis, which is diffuse actinic keratoses. And that is something that should be treated because lips and ears, if it transforms into squamous cell cancer, has a much higher chance of killing someone rather than a squamous cell elsewhere. So some of the treatment options, I mean, liquid nitrogen obviously is the treatment of choice and it's the quickest, so we do a lot of that. You can also curette them, you just numb them up and scrape them off. 5-fluorouracil, so they interestingly found that in cancer patients, colon cancer patients, they were treating them with 5-fluorouracil and all of their AKs were lighting up. And so that's how they decided to use 5-fluorouracil as a topical treatment. And they can still sometimes get systemic symptoms. There is actually a genetic abnormality in certain Caucasian populations where they can actually get systemic absorption significantly and get really sick, and there's actually been reports of death with that. So I normally don't treat widespread at the beginning. I normally would tell them to treat a small area for like a couple of days or a week, and if there's no problem, then they can treat larger areas. Imiquimod also has a risk of treating larger areas and absorbing and getting flu-like symptoms. Now that one is not life-threatening, but that's actually very common to get flu-like symptoms with imiquimod. Diclofenac is an anti-inflammatory. You treat them for 90 days. It's never covered by insurance and it takes forever, so I rarely ever write that. Ingenol Miputake is a natural product. It's potato. I use that one a lot. You only have to treat them for 3 days on the face, and they get their reaction for 10 to 14 days, and it's wonderful. All the other treatments are like 2 to 4 weeks that you're treating them. And this one is normally well covered by Medicare. Pretty good, actually. Photodynamic therapy, I don't do that in my office, but it's very sore, but it works very well on sun-exposed areas. And then you can do chemical, pill, or laser, but those are not that commonly done. I think I will blur through these and get to the emergency one. So I'm just going to show you the pictures and then we'll go through it. So these are different forms of basal cell cancer. Yeah? So that's a superficial basal cell cancer. It looks like a dermatitis or more of a rash almost. That's a pigmented basal cell carcinoma. So we see that commonly in Hawaii. A lot of Asian skin has pigmented basal cells. These are more getting classic pigmented basal cells that you can see. Kind of looks like melanoma, yeah? This is a morpheoform basal cell cancer, so it's kind of ill-defined. You can't really see where it starts and ends. And then we start to get to the big ones. So the guy on the left is probably has a genetic disorder, the basal cell nevus syndrome, where they get tons of large basal cells, or you have radiation. And the one on the right is just a neglected basal cell cancer. And then this is your classic rodent ulcer, when you think of a basal cell cancer. So in a nutshell, basal cell cancer is most common skin cancer. Not going to kill you, but it can definitely get cosmetically deforming if you leave it alone. So we'll freeze them, we'll cut them out, we'll scrape them out. And if it's big or it's on the face, we'll do most surgery for those guys. Sorry, I'm going to blur through these because I know I have like a couple minutes left. So if you have any questions, still feel free to stop me if you want to about any of these things. Squamous cell cancers, so that's what these guys are. So I mentioned the lip has a much higher chance of killing someone. I think it's like a 10 to 14% chance of metastasis for an untreated squamous cell cancer in the lip. Yeah, lips, ears, and genitalia involve a much higher metastasis rate. The one thing I do want to bring up is that 4th bullet point down, keratoacanthomas. So those are rapidly enlarging nodules that have a little core in the middle. They're actually very common. So if you see a growth that rapidly enlarges really quickly, people get worried. They should still be seen, but those actually have a good chance of going away on their own. So if you have your typical dermatologist that can't see people for 3 to 6 months, it might be gone by the time they get in, but you know, we would squeeze in people for that, so don't worry. So they actually just start to shrink, and some of them either will scab off or they'll actually just kind of resort back into the skin again. Yeah. So they look nasty. I mean, they're big Goombas with little cores in the middle, but they, yeah. So I still treat them anyways because the only way you're going to know which one it is if you let it go. And if it was a rapidly, you know, for some reason, a poorly differentiated squamous cell cancer that you let go, then you have problems. So I'll normally treat them not as aggressively. So I'll normally just EDNC them or scrape them out, or I'll just freeze the heck out of them. I won't normally cut them out. Yeah. And most of the time when we're treating them, we're biopsying them too. So when the biopsy report comes back, if it was a poorly differentiated squamous cell cancer, then I would go back and cut it out or send it to Mohs surgery after. So these are a couple of my emergency ones. I think I have 2 of them here. So it's kind of like a purpuric patch. You can have these large ulcerations in the lower leg. So this is calciphylaxis, and you guys probably have a lot of dialysis patients. I mean, it's one of those things that you can definitely see, and it is considered an emergency. They often will complain at this phase of just pain. You know, it hurts, it's a little bruised looking, but you don't see much going on, and then quickly it evolves into ulcers. And it's pretty rare. I think I've only seen 1 case of this, and it's most commonly seen in obese females on dialysis. And they say the obesity because the fat tends to be where it necroses the most. And the kidney disease part is because they do believe you have a higher phosphate calcium ratio, and your hyperparathyroidism will kick in and excrete more calcium because it doesn't see the calcium. It's a whole physiology thing, and you'll just keep on pumping out more calcium in your blood, and then it can definitely clog up blood vessels and lead to this calciphylaxis. So the treatments for the clinical, I think we kind of went over that. It tends to be really sore, tender ulcers or purpuric areas over fatty locations. So phosphate binders, sodium thiosulfate is a great treatment. I don't know about the surgical debridement part so much. I think you should try to correct the underlying problem. Parathyroidectomy is actually pretty common, and a lot of people die from this. I mean, it's considered an end-stage disease process. This one, I have two more. This one is dress. So, non-specific rash. I mean, this is your classic morbilliform eruption. You should be thinking of drugs versus bugs, a viral infection or a medication reaction. So there definitely is HLA types. For Hawaii, I think it's actually kind of important because a lot of Han Chinese and other ethnicities have a higher incidence of certain rashes. And I've seen maybe 3 in the hospital that I was consulted on, and they were all allopurinol. Definitely anticonvulsants, I think, are classically the more common one, and antimicrobial is the second most common one. And it's something that doesn't happen right away. So it's normally a couple weeks to a month after you start the medication, not your usual right away you see the rash. And every time you get re-exposed to it, it gets worse quickly. Fever and rash are the 2 most common presenting symptoms at the beginning. And edema of the face is supposed to be a classic sign of this along with the rash. So if you see someone with a big face and they have that morbilliform rash and they started one of these medicines a month ago, you're in the right category if you're thinking of this condition. They don't tend to get so much of the blistering like Stevens-Johnson and the erosion in the mouth sores, but they can, but it tends to be just more morbilliform rash and then internal things that you need to look out for. So this list over here, I mean, we're listing almost every body part you can think of. It can absolutely affect all internal organs. So there definitely needs to be a broad workup if you're thinking about this condition. So besides the broad workup, the TSH with free T4 is the one thing that's interesting. If you discharge someone who has this diagnosis, you got to make sure their primary care doctor is checking their thyroid function after, because that can absolutely be a late manifestation a year or 2 after this disease is done. So it's a little pearl. And then the last one. So these are your classic target lesions. Yeah. And we start to get some mucositis. And we have raw areas all over the place. And I did not put the answer, but this is the overlap Stevens-Johnson and TEN. Interesting here, definitely a high death rate. So the associated drugs, allopurinol, antibiotics, NSAIDs, and anticonvulsants. The one case I can remember recently was actually someone who walked into my office as a walk-in patient, and his was Bactrim, I believe. You don't normally see them as an outpatient. I mean, normally they're in the hospital and you get consult on them, so. And it might just be burning in mucosal areas. They may not even have any skin findings at the beginning, and then it normally rapidly progresses. And the dusky target lesions I mentioned at the beginning can be the early signs of impending TEN. They complain of pain at the beginning, and then when they stop complaining of pain, then you know there's a problem, because that means kind of like a burn. That means all the nerves are dead and the skin's dying off. That's when you get the full thickness necrosis. That's when the pain kind of starts to go away. And from medical school, we all remember Nikolsky sign. That's when you do lateral traction and the blister will spread because the skin's basically sloughing off. As will Hansen signs when you push down on a blister, and it also causes it to spread as well. Do I actually do those? Not really. But sure, they're useful, I guess. And then there's the criteria. The Stevens-Johnson is just by body surface area. Stevens-Johnson TEN is intermediate, and then TEN is greater than 30%. You definitely want to consult ophthalmology, GYN if it's a female, or urology if it's a male. Anything that has mucosal areas at ENT too, because they can definitely get scarring and permanent dysfunction in those areas. And then lastly, so this is controversial how you would treat them. The first part is not. They should be in the ICU or burn unit and checking their electrolyte and volume status. But the bottom part, steroids versus IVIG, I mean, a lot of people think IVIG is the answer. That should be the answer. A lot of more recent studies over the past year or 2 have actually shown higher mortality right now with IVIG. So cyclosporin is actually considered a treatment of choice among the dermatology community now, as long as they can tolerate it and their kidneys are not shot. And it's high doses. I believe it's 4 to 5 milligrams per kilogram. And then if you happen to have a dermatologist who has Enbrel or etanercept in his fridge in their office as samples, which I'm not saying I do, but I might, That is supposed to be great. It's one shot and it's supposed to significantly help reduce the progression of the disease. And I just put this on there because like 90% of my pictures came from this website, and they say as long as I put this on there that it's okay. So I'm just putting that up there. And then that's it. All right, sorry for going a little over there. Does anybody have any questions about anything, not even related to my talk or anything else skin related? Good. All right, thank you guys.